Hello. We've now reached section 8. We're continuing our discussion of pharmacodynamics. Last class we ended up talking about drug-receptor interactions. Today we're going to take that knowledge and we're going to go one step further to have a discussion about dose response. Again, to refresh our memory, dose response is a component of pharmacodynamics, how the body responds to drugs that are in situ. We think of dose response under two primary headings, efficacy and toxicity. So our objectives for section 8 are the following: define potency and efficacy, be able to appreciate the concept of dose-response relationships, know how to interpret dose-response curves, explain how dose-response curves are used to calculate the therapeutic index. So let's start off with the why. Why do we bother with this information? Well, first and foremost, dose-response relationships help to clarify the proper dose of a given drug that produces the desired therapeutic effect while limiting harmful side effects. We want the drug to work. We don't want the drug to make the individual feel poorly. To analyze the relationship between dose and effect, we construct mathematical plots of the relationship. Before we get into the discussion of dose-response relationships, let me just re-emphasize the concept of efficacy as well as toxicity. Depending on the scenario in which we are treating a patient, we have a certain threshold of toxicity that is acceptable to both the patient and to us as the healthcare provider. In some circumstances, that threshold may be very high. In other circumstances, that threshold may be very low. We'll use that analogy today as we discuss the nature between dose and response, emphasizing the concept that the response includes both the efficacious response as well as the toxic response. So in advance of going through this slide, let me apologize. I'm sure many of you don't have any great love of kinetic relationships. So let me try and make this information as simple as I can. For those of you who are chemistry students or biochemistry students, this equation at the top of the slide will actually look pretty familiar to you. This is simple enzyme kinetics that you may have seen in chemistry previously. So here we are looking at the relationship between a drug here and a receptor giving rise to a receptor-drug complex. This is what we talked about in our last class. The idea being that the drug-receptor complex brings around an effect. In pharmacology and in clinical medicine, we want to know several things about this relationship. First of all, we want to know what the affinity the drug has for the receptor, what sort of nature this drug-receptor interaction actually has, the components of that relationship. And then we want to know not only when the drug is bound to the receptor, what's the size of the effect, recognizing that the effect may be good or bad effects. So we have to be able to have integers of measurement to be able to quantify this type of response. So let me introduce the first one to you. And this is the equilibrium dissociation constant, much easier to say KD for short. And this is defined as the concentration of the drug producing half maximum binding. So the amount of drug in the particular setting that occupies 50% of the receptors that are available. And what the KD gives you is a sense of the affinity of the drug for the receptor. And it's defined really by the nature of the forward reaction, i.e. the K1, in relation to the backward reaction, K2. So from a mathematical perspective, the equilibrium dissociation constant, KD, is equal to the K2 divided by the K1. Now, please remember that here we're talking about affinity, binding of the drug to the receptor. We're not talking about efficacy. That's the latter part of the equation. So moving then to talk about the effect. What is the effect size? And this is denoted by K3, or the value of K3. And K3 is defined as the intrinsic activity of the drug-bound receptor. What's it capable of bringing about? What change in response to the drug bound to the receptor can be witnessed? A K3 that has a value of 1 is considered an agonist, i.e. it produces a positive effect. A K3 that is equal to 0 is considered an antagonist, a lack of effect. But remember what we said previously, that we also have drugs that function as partial agonists. In other words, they're not as strong or as potent as a full agonist, and therefore they're going to have a K3 value that falls somewhere greater than 0 because it's not an antagonist, but less than 1 because it's not a full agonist. So that's the principle of K3. So we've introduced the concept of drug plus receptor equals drug-receptor complex, and the forward direction of that relationship is ultimately going to give you a reflection of the affinity of the drug for the receptor, and then the K3 value is going to give you, in essence, a sense of the magnitude of the effect that that drug-bound receptor can bring about. In addition to this, we use the following terms. First of all, potency. Potency is defined as the concentration of the drug required to achieve a certain effect. Again, we like to reduce these things to mathematical perspective, and here we refer to as the EC50. And this is the concentration of the drug producing 50% of the maximum effect seen. Let me repeat that. The EC50, which is a measure of potency, is the concentration of the drug producing 50% of the maximum effect that is feasible. The EC50 and the KD are usually equal, unless there are what are called spare receptors. I'm not going to spend a lot of time explaining spare receptors, but let me simplify it as follows. For most extents and purposes, we consider a drug in an environment occupying all the receptors. But there is always the consideration that there are receptors that are not occupied, and these are referred to as spare receptors. If there are indeed spare receptors in any system, then the KD and the EC50 will not be equal. But for the level at which we're teaching this course, you can consider them equal for all the examples that I'm going to show you. Another term that I would like you to have a good understanding of is efficacy. And efficacy is the magnitude of the drug's action at the limit of its concentration. And this is referred to as Emax. So we have EC50, referring as a measure of potency, and we have Emax as a measure of efficacy. And I'd like you to think about that for a second, because very often we use the terms in lay practice or in lay language of potency and efficacy as interchangeable. With respect to drugs, they are most definitely not interchangeable. Potency and efficacy reflect two very distinct, different concepts. So let's look at it in a pictorial sense. As we've said many times before, a picture speaks 1,000 words. In both of these panels, on the x-axis, you have drug concentration. And on the y-axis, in the panel A, you have drug effect, efficacy. In panel B, you have receptor-bound drug. So this is more the concept of the KD value, the equilibrium dissociation constant. You can see that both of these curves are remarkably similar. Again, what I've said to you before, we're going to represent systems to you in class today that preclude the concept of spare receptors. So these two curves should overlap. At the top of the efficacy dose-response curve, you can see an arrow pointing to Emax. This is the maximum effect at the drug concentration achieved. Over on the right-hand side, the B refers to bound receptor. The bound receptor at the maximum of drug concentration going out along the x-axis. In terms of EC50, remembering what we said previously, the EC50 is the concentration of the drug producing 50% of the maximum effect. So where is that on panel A? Well, you just look at your y-axis and you see where the 50% mark lies. You draw a horizontal line over to your dose-response curve, and then you drop a vertical down onto the x-axis, which is the drug concentration axis. So at this concentration, let's call this concentration X, drug concentration X, produces 50% of the response as seen on the y-axis. This is referred to as EC50. Assuming no spare receptors, the KD is calculated in exactly the same way, the only difference here being the y-axis representing receptor-bound drug. So this concept of efficacy overlapping with the dissociation constant shows the similarity between these two principles. So when you look at panels or graphs such as these, it's very easy to say that there's a definite dose-response relationship. As you increase the dose here on the x-axis shown in milligrams, there is an increase in response. From a mathematical perspective, however, these curves are difficult to work with. There's no flat part in the curve, and we appreciate that there's much greater change in the earlier parts of the curve than there are in the latter parts of the curve. The steepest part of the dose-response curve is typically seen at the beginning of the dose-response curve. So for these two reasons, we convert these hyperbolic curves into more manageable curves. So we always talk about log dose response curve. So this is that exact same curve converted. So here we see the log of the dose on the x-axis with the same variable on the y-axis. And what you can see in this particular graph is you have a very sizable central portion that is a straight line. And we like straight lines, easier to make accurate determinations at straight lines. So what can we see on this curve? Well, first of all, represented up at the top is the Emax, the maximum response or the efficacy, the maximum efficacy that is seen in response to increasing doses. We also have this concept of the threshold dose. This is where you begin to see a response. Somewhat arbitrarily on this diagram, it's shown when you get 10% of the population responding to whatever intervention is at hand. Sometimes it can be the magnitude of blood pressure reduction, the magnitude of pain relief, etc. In addition to this, then we have the ceiling dose, and this isn't showing up very well in this slide. However, the ceiling dose is typically where the maximum response drops down onto the x-axis, and the ceiling dose is the same as the Emax. And then if we go there we go, there's my vertical line. And then if we go one step further, we're looking for the EC50. So look at the 50% mark or the halfway point on your y-axis, draw a vertical line down to your x-axis, and now you've got your EC50. And assuming there are no spare receptors, your KD equals your EC50. Now, we can use these curves and we can superimpose them on curves in response to other drugs to be able to make some sort of comparison. For example, saying that one drug is more potent than another drug is equally efficacious to another, determining if a drug is a full agonist or a partial agonist, etc. So these curves are the mainstay of dose-response relationships. And we spend a lot of time looking at these types of curves during the drug development process. And just to give you an example, on the x-axis again, you have a log of the concentration or the dose of the agonist. Let's say you've got 4 different drugs in play here. And on the y-axis, you have the effect, whatever the effect you might be looking for. So look at this slide, if you will, for a few moments with me and ask yourself some pretty simple questions. What's the difference between each of these curves, assuming that each curve represents a single drug given in isolation? So while you think about that, I want you to think of 2 concepts, potency and efficacy. And think about how you might compare these in that regard. So first of all, the way we look at these curves is we evaluate efficacy. So where is the maximum response rate? So if you're following along with me, I hope you can appreciate that the curve for drug A and the curve for drug B have equal efficacy or equal effectiveness. Their Emax is attained in and around here, and it equals they match each other. They equal an equal agonist effect. So drug A and drug B have the same Emax, and they're equally efficacious. The next question, however, is, are they equipotent? Do they share the same degree of potency? Now, I'll share with you a trick of the trade, if you will. Curves that are most to the left are maximally potent in comparison to the curves that are to the right. Why is that? Well, think about how we measure potency. You remember that term? EC50. So let's say we were to take the 50% response rate along the x-axis. It's going to be somewhere in here. And as we said previously, we draw a horizontal line out to the point where it intersects with your dose-response curve. You then drop a vertical line down to your x-axis, and that's your EC50. So if you do it for drug A, you're going to end up with your mark being somewhere around here. This is your EC50 for drug A. Now let's do exactly the same thing for drug B. Your horizontal line is going to be the same. It's going to follow out to your dose-response curve for drug B, and you're going to drop this down to the x-axis. And this here is the EC50 for drug B. So you can appreciate that drug A produces a greater response at a lower concentration than drug B. Thus, drug A is more potent than drug B. Well, what about drug C and drug D? Well, straight off the bat, you can appreciate that they are not as efficacious as either drug A or drug B. And if you look at potency, if you draw your arrow out a little bit further to drug C, you're looking at the 50% response rate as being somewhere around here, dropping down your vertical. So not only is it not only equally efficacious, but it's less potent. So this concept of efficacy and potency is an important deliberative process, because potency isn't always the measure of the response that we're looking for. It's efficacy. And what we ultimately want to try and do is match efficacy with toxicity or tolerability. So we want the drug to work, but we also want it to produce the least amount of toxicity. Now, you can calculate dose-response curves for an efficacy response, but you can also calculate dose-response curves for a toxicity response. It's just not typically as reproducible as efficacy. This is showing you pretty much the same thing, emphasizing here we're looking at 4 different dose-response curves, again, A, B, C, D, and E, and showing you the various EC50s at the different points along the x-axis. These are all examples of graded dose-response curves. And when we ask the broad, high-level question, what types of dose-response curves are there? We essentially divide them into 2 types. The graded dose-response curve, and I just showed you a bunch of fictitious graphs. And on these, we were able to see that with increasing dose, you see an increase in response. For example, increasing doses of oxycodone, a narcotic, improves pain release or relief, induces analgesia. Increasing doses of alcohol causes increasing degrees of psychomotor impairment. I'm going to show you an example of that for ease of reference. And the graded dose-response curves are commonly utilized for assessing both safety and efficacy, because we want to have this sense of margin for where is the margin of efficacy witnessed, where is the margin for safety evident. And then there's a second type of dose response curve, which we will also talk about. And these are quantile dose response curves. And another way of saying this more colloquially is the all or none phenomenon. The percentage of rodents dead versus alive. That's a pretty definitive difference between the two. The effectiveness of an oral contraceptive. The patients either become pregnant or they don't become pregnant. There's no midway point there. And what we typically use quantile dose response curves for is for assessments of safety, because they're very rigorous. They're very definitive in many regards. So you've got graded dose response curves and you've got quantile dose response curves. So let's just make things a little bit more lighthearted for a moment. And let's use, for an example, a graded dose response curve in response to doing something that is pretty common socially, which is drinking alcohol. So our fictitious example here on the x-axis is the number of alcoholic beverages, or in this example, martinis, imbibed. On the y-axis is what we would, from a social perspective, appreciate that happens after social drinking. So in this particular example, we can say that after an individual has drunk maybe 2 glasses or 2 units or 2 drinks, they become more verbose, more social, tend to talk a little bit more, very nice and pleasant. After maybe a few more drinks, well, then we become happier. And the element that's interplaying here is that alcohol is causing a degree of disinhibition. So there's a degree of laughter, which is kind of on the edge, but it is definitely occurring in a dose-response manner. This somewhat comical depiction in the bottom right-hand corner is described here on the y-axis, a little bit tongue-in-cheek, as bellicose, argumentative, fighting a little bit, just a bit obstreperous overall, following out this dose-response curve. Then we tend to see people who've drunk even a little bit more starting to become a little bit morose or sad. Then after that becomes the sleepy stage. And this is where the humor probably disappears from the conversation, where the respiratory center in the brain becomes depressed and the ability to sustain respiration is compromised, and the patient becomes difficult to arouse, and then obviously the level that we would not like to go to, which is ultimate complete respiratory depression and death. So although this is a somewhat lighthearted approach, it represents what I'm trying to get a point I'm trying to get across. This very traditional dose-response curve that we witness following social drinking. Now let's bring it back into the clinical setting. Pain relief is something that most people who are listening to this class have either experienced firsthand or in the care of their loved ones or patients under their care. So here we have 3 different drugs. Oxycodone, which is a narcotic analgesic, and it provides its effect through the mu receptor, one of the opioid receptors. Codeine, also working through this same receptor. And then Tylenol, or acetaminophen, over on the right-hand side, abbreviated APAP, which is its chemical name, just fit into the slide with a little bit more ease. On the x-axis here is the log dose in milligrams, so we can see incremental doses. And then on the y-axis is a scale, a self-report scale, so somewhat of a qualitative assessment of pain relief, where the individuals completing this are instructed that 0 equals no pain, or 0 equals no pain relief, and 4 equals complete pain relief, or the absence of any pain whatsoever. So these are 3 dose response curves of 3 common analgesics that are used in clinical practice today. What can you say about these particular dose response curves? Well, I think that you're probably getting the picture here. One is, if you look at the Emax for oxycodone and for codeine, they are the same. They achieve the same maximal response. So they are equally efficacious drugs. If we look at the potency of the 2 drugs, however, we see that oxycodone is ballpark 12 times more potent than codeine. So a more potent drug, but an equally efficacious drug. And then over on the right-hand side, you can appreciate that the dose-response curve for APAP or acetaminophen shows that it is less efficacious and less potent than either codeine or oxycodone. So what do you think you do with information like this? Do we go around using the most potent drug all the time? Well, obviously the answer to that question is no, because in clinical practice what we're trying to do is not only induce the response that we're looking for, in this example pain relief, but we also want it to mirror the toxicity profile. So the sort of toxicity profile that you might see in comparison to these sorts of drugs being used in clinical practice is reflected here. And these data are actually data from a clinical trial conducted by one of my colleagues here at the University of Pennsylvania. So in this example, you're looking at a clinical trial, and in this clinical trial, these were all individuals who underwent a dental procedure, and they were administered either placebo, a sugar inactive pill, Tylenol, acetaminophen, or Tylenol together with oxycodone at a lower dose or a higher dose. So Tylenol at 500 with oxycodone 5 milligrams, or Tylenol a gram together with oxycodone 10 milligrams. And the primary question here was not only which of these combinations was more efficacious, and going into it, of course, you have the premise that the highest dose of Tylenol together with oxycodone is going to be more efficacious in terms of pain relief. But really the primary point of interest here is what's the toxicity profile for this general type of therapeutic approach. So on the left-hand side down here is looking at the common anticipated sorts of side effects with Tylenol or oxycodone. And they include nausea, drowsiness, dizziness, lightheadedness and headaches. And then calculated in the red is the number of side effects experienced overall in that group. And then in the green is the number of subjects with side effects. Okay, so two different ways of looking at toxicity. And what you can clearly see is more nausea was associated with both treatment groups that incorporated oxycodone, and that the higher the dose of oxycodone, the greater the degree of nausea, or the greater number of subjects who experienced nausea. In addition, increasing degrees of drowsiness, although I'm sure if you put this to statistical testing, this would not reach statistical significance, but we leave that point aside. Very significant differences between dizziness, and then if we look at the overall number of side effects, no question that the higher dose of Tylenol and the higher dose of oxycodone was a less tolerated, less well-tolerated, more toxic intervention in comparison to either Tylenol or the lower doses. So we use this sort of information in order to be able to choose appropriate medications. I said to you before, we have acceptable levels of toxicity depending on the scenario that we're treating. For example, if we have a patient who has extensive bony metastases with end-stage malignancy, pain control is a primary concern for the humane treatment of that particular patient. In that sort of scenario, we are much more willing to accept a greater spectrum of toxicity from that drug than we would in a patient who's undergoing a dental procedure. So the concept of dose response and balancing efficacy and toxicity always has to be considered within the clinical realm in which the drug is actually being used for clinical purposes. So let's now look at a little bit about receptor interaction, returning to our last class in which we looked at drug receptor interfaces. And in these next series of slides, we're using a very schematic representation of the receptor, recognizing that this is absolutely just a schema and that we've previously described the 5 main types of receptor subtypes. So here we see a receptor portrayed, and we have the binding site here, and we have the activity site. So we know that every receptor has a location on that receptor where molecules will bind to it, agonists, antagonists, etc. However, there is a unique activity site that needs to be activated in order for the receptor-bound drug-bound receptor to be able to bring about its response, and that's referred to as the activity site. So if we look in this particular setting, we have a molecule, a drug, that functions as an agonist. The K3 equals 1. We see it inserting into the binding site and the activity site, and it is this interaction that brings about the drug response. This is a pictorial depiction of a drug functioning as an agonist. An example here is what I've just showed you from the previous graph, oxycodone. It's an opiate receptor agonist, and it has a K3 that is equal to 1. Let's move on to another example, and in this case, it's an antagonist. So the drug is binding to the receptor, but remember our definition of the antagonist. It prevents the activation of the active site of the receptor. So in this example, it shows the drug literally covering the activity site. And this is, of course, a ridiculous degree of oversimplification. But the concept here is that the antagonist in situ prevents the natural agonist from binding. So let's say, for example, we're treating a patient with high blood pressure, and we know that angiotensin II is the normal hormone that causes an increase in blood pressure. And we have a group of drugs called angiotensin receptor blockers. These drugs would bind to the binding site, but they would block off access to the activity site so that angiotensin II, the natural agonist, cannot get access to the activity site, and thus the blood pressure is lower. This is a classic example of a drug antagonist. And one of the things about antagonists is that their binding to the receptor is typically very tight. So it typically gets in there and it sits there and it binds. In this particular example, we have naloxone. And naloxone is an opiate receptor antagonist. And by definition, its K3 equals 0 because it does not permit any intrinsic activity to be seen. So you could imagine the potential utility of naloxone in somebody who has overdosed with an opioid narcotic, because it can prevent the ability of the opioid narcotic to actually bind to the receptor. And I'll return to this slide just one more time. In here, the agonist binding, you can see inserts into the binding site and inserts into the activity site. One of the things about agonists is that they come onto the receptor, they come off the receptor. So they are bound and then they're unbound. So it's a very dynamic relationship between the agonist binding to the receptor. So let's look now at our third example, and this is an example of a partial agonist. So again, the partial agonist is able to bind to the binding site, but it's not terribly efficient at the activity site. So its efficacy is not going to be as optimal as our full agonist. And if you will recall before, we said that partial agonist, our example here is buprenorphine, and it is an opiate receptor partial agonist. Its K3 is between 0 and 1, and here being depicted as having a value of 0.7. Now, this example, or this model system of opiate receptor activity, is actually a very useful model, because what it helps us to emphasize is the interplay in the setting of an agonist, a partial agonist, and an antagonist. So let's say, for example, a patient comes into the emergency room and they've overdosed on an opioid narcotic. They've been given a prescription for pain relief, and for whatever reason, they have too much opioid narcotic in their drug system. And you can kind of visualize from a perspective that the opioid narcotic is binding to the binding site, is gaining access to the activity site. And one of the things that opiate narcotics do is they depress respiration, and they can cause a respiratory arrest and death if they are overdosed to a significant degree. So in the emergency room, what the healthcare providers are trying to do is not only maintain the breathing for the patient who is in front of them, but they also want to minimize the activity of the narcotic as quickly as they can. So what are their options? What's available to them? Well, first of all, naloxone is a good approach because it's going to function as an antagonist. It's going to compete with the agonist, the overdose drug, the opiate in this particular setting, and ultimately attempt to minimize that effect. Another approach is to give a partial agonist. So in this situation, what you're doing is you're gradually diminishing the effect. And this might be very useful in narcotic dependency, where you don't want to withdraw the drug very precipitously because you can get a lot of adverse rebound effects from withdrawing narcotics precipitously. So we can use partial agonists to kind of slowly dampen down the response because they will also compete for the activity site in the same manner that the natural agonist would. So this interplay between agonist, antagonist, and partial agonist is quite nicely represented by the opioid receptor and these three drugs, oxycodone, naloxone, and buprenorphine. So this leads into a discussion of the types of antagonism. So we essentially have four different types of antagonism: competitive, non-competitive, chemical, and physiologic. And I'm going to start from the bottom and work my way up. So physiologic antagonism is defined as one drug doing exactly the opposite of another drug and works through a different receptor. You will recall that when we were talking about receptor signaling mechanisms, we used the example of a bee sting. And we described how histamine, mediating its effect through the histamine 1 receptor, can induce a vasoconstrictive and a bronchoconstrictive response on airways. And that one of the treatment approaches is to use epinephrine mediating its effect on a beta 1 receptor, bringing about a contrasting vasodilatory or a bronchorelaxation therapeutic effect. So in this example, epinephrine is functioning as a physiologic antagonist to histamine. So that's physiologic antagonism. In reality, both drugs are functioning as agonists, but one of the agonists has an opposing physiologic effect to the other. A second is chemical antagonism, and this you may be familiar with. This is the concept that you're taking more than one drug at a given time, and that one drug binds to or inactivates another drug and prevents its absorption. A good example of this is divalent and trivalent cations with dairy products, antacids and iron supplements, when given together with tetracycline, can markedly alter the absorption of tetracycline. Another good example is a drug called cholestyramine. This is a bile acid sequestrant, and cholestyramine can actually bind immunosuppressive drugs and prevent their absorption. So this is an example of a chemical interaction between molecules that alters the percentage of the drug that is absorbed and thus bioavailable. And then the two that are more relevant to clinical pharmacology from a pure principle perspective are competitive antagonists and non-competitive antagonism. So competitive antagonism involves receptors. It is reversible as long as you deliver enough agonism. In other words, it's surmountable. So you can have a degree of antagonism on board, but if you keep on increasing the dose of the agonist, you'll overcome the antagonist. And this is this idea of receptors binding drugs. So drugs come onto receptors, they come off the receptors. So there's the opportunity for competition for the binding sites. Non-competitive antagonists, even though they involve receptors, they bind so tightly, you don't have this on-off phenomenon, that it doesn't make any difference how much more agonists you give, it fails to reverse the effect of the non-competitive antagonist. And we're going to look at some examples here. So using the same curve that I showed you previously, we have 5 different dose response curves. Now remember what we said. Oxycodone is an agonist, a full agonist, K3 equals 0. We said that naloxone is a antagonist, K3 equals, let me back up. Oxycodone is a full agonist and the K3 equals 1. Naloxone is an antagonist and the K3 equals 0. The buprenorphine is a partial agonist and its K3 is 0.7, so between 0 and 1. Okay, so let's think about this. First of all, what happens if you give naloxone on its own? Well, here, as you see, it's a flat line. It's no dose-response curve. It's an antagonist, but it doesn't have anything to antagonize, so it's not bringing about a response. It's preventing a response, okay? Oxycodone, given on its own, shows the typical dose-response curve. You can see its EC50, you can see its Emax. What happens if you put on top of that naloxone, an antagonist, at a dose of, in this example, we use 0.2 milligrams? Well, it shifts the dose-response curve to the right. It reduces the potency. It doesn't change the Emax, and you can overcome it. If you increase the dose of oxycodone, you will overcome the antagonism of naloxone because it is a competitive antagonist. Here you see an increasing dose of naloxone, shifting the curve further to the right, representing that as you increase the dose of the naloxone, you get an ever-increasing antagonism of the effect of oxycodone on the opioid receptors. And in this example here, we see buprenorphine. Buprenorphine, because it's a partial agonist, is going to diminish the response to the opioid receptor. So this is a nice depiction of the dose-response curves and the interplay between the agonist, the partial agonist, and different doses of the antagonist, in addition to the antagonist on its own. And here we see the vertical lines dropping down, showing that the EC50 is increasing in the presence of increasing doses of the antagonist naloxone. Looking at a different model system, in this example, we have a competitive antagonist and a non-competitive antagonist. So acetylcholine, as we've told you before, is the neurotransmitter in the parasympathetic nervous system. On the y-axis is muscle contraction. Acetylcholine, or the parasympathetic nervous system, increases muscle contraction. And we've also discussed ways in which it regulates heart rate. So here we see in red the dose-response curve to increasing doses of acetylcholine. So as you increase the dose of acetylcholine, you increase the degree of muscle contraction strength. You can calculate the EC50 by dropping down a vertical line to the x-axis at the 50% response rate. In the presence of curare, which is a competitive antagonist to the acetylcholine muscarinic receptors, nicotinic receptors, you shift the dose-response curve to the right. And here you can see that the EC50 is at a much further point along the dose, the concentration of the drug on the x-axis. If you look at succinylcholine, succinylcholine is a non-competitive antagonist. It will bind to the nicotinic receptors on smooth muscle cells and skeletal muscle cells and will prevent binding of acetylcholine. So in this situation, you see a very marked diminution of muscle contraction in the setting of succinylcholine. So this graph is in place to try and emphasize the difference between competitive and non-competitive antagonism. And I just wanted to give you some examples that you may be familiar with. Don't worry if you're not. It's purely just for depiction purposes. So the muscarinic cholinergic receptor, the natural agonist is acetylcholine. We also have drugs, synthetic drugs, pilocarpine, for example, and then antagonists, atropine and scopolamine. Atropine, we've talked a little bit about before, antagonizes the impact of acetylcholine in the heart and causes a alteration in heart rate. Scopolamine is a drug that we use for motion sickness, and it antagonizes muscarinic receptors in the brain that mediate the nausea and emesis associated with repetitive motion. Nicotinic cholinergic receptors, the natural agonist is acetylcholine, and also nicotine, either from chewing tobacco or from smoking. And the natural antagonist, the competitive antagonist is curare, and the non-competitive antagonist is succinylcholine. The alpha-1 adrenergic receptor, the natural agonist, is norepinephrine and epinephrine, and both of these are available as a therapeutic. And the antagonists are prazosin, which for a long time was used in the treatment of hypertension, and phentolamine, which is used in the domain of anesthesia. Beta-1 adrenergic receptor, the natural agonist, is epinephrine, and commonly used antagonists, propranolol and metoprolol, are used to control blood pressure, to lower blood pressure, and also to prevent recurrent cardiovascular events, heart attack, etc. So now let's return to what we mentioned previously, quantile dose response curves. And to remind you, these are all or none dose response curves. And typically the way we look at these is from a percentage perspective. So the example given here is percentage of rodents dead at a given dose of a drug called phenobarbital, which is a CNS depressant. So we are going to use an example here of an experiment that involves giving a drug, in this example, the anxiolytic diazepam, marketed in the US as Valium, to a total of 50 rats. And on the x-axis, you can see that there are increasing doses of diazepam from 0 milligrams up to 200 milligrams. The difference here is that on the y-axis, it's a representation of the total number of rats asleep. But the assessment is what's called a cumulative percent asleep. So in the schema on the right-hand side of this graph, you'll see incremental doses of 20 milligrams up to 200 milligrams. And what you're essentially doing is calculating at each dose what the incremental number of animals who are asleep. So this is the efficacy piece. You're giving diazepam to make these animals sleepy. And we calculate the EC50 in exactly the same way, where 50% of the animals have the effect that we want. And the dose at which 50% of the rats were asleep was 100 milligrams. So we can say that the EC50 for diazepam in this model was 100 milligrams of diazepam. Now, what we really want to know is at what point does this efficacy become problematic? So with quantile dose response curves, what we're able to do is compare the dose at which 50% of the rats are asleep to the dose at which 50% of the rats are dead. And we calculate this as a cumulative percentage dead. So you're looking at cumulative percentage asleep, and you're comparing it to cumulative percentage dead. And in this particular example, you see that 50% of the rats died when the dose of Valium was 4,000 milligrams. So the wanted effect was seen at 100 milligrams of Valium. The lethal dose was seen at 4,000 milligrams. So very wide disparity between the effective dose and the lethal dose. And this is very important to us because from it we're able to look at the EC50 for diazepam shown in red and the and the lethal dose at which 50% of the animals were dead shown in blue. And this is referred to as the LD50. So in order to calculate the therapeutic index, we do a comparison, a mathematical comparison. And we say that the therapeutic index is equal to the lethal dose, the dose at which 50% of the lethality was demonstrated, divided by the effective dose, where 50% of the rodents experienced the effect that was intended. So the therapeutic index in this particular example is 4,000 milligrams, the lethal dose, divided by 100 milligrams, and the therapeutic index has no annotation to it. It's 40, because the 2 milligrams obviously cancel each other out. Now, a therapeutic index of 40 is considered to be very wide, and for this reason we consider diazepam to be a relatively safe drug for that very reason. However, we have examples from human pharmacology where the lethal dose and the therapeutic dose is not that close, and that can be a real concern in clinical practice, where we want to be very sure about how drugs are compared to each other. So the therapeutic index, for example, that we've shown for diazepam can be used as a benchmark against which we compare other drugs. And this is what this particular graph is attempting to do. So as we've said, the ED50 for diazepam was 100 milligrams, and the LD50 for diazepam was 4,000 milligrams, which gave us an overall therapeutic index of 40. However, let's compare it to phenobarbital. This was a drug used as a sleep aid very commonly back in the 1960s. So let's look at the ED50 for phenobarbital. Not that dissimilar at all to the ED50 for diazepam. But when we now look at the LD50 for phenobarbital, we see that in fact it's an awful lot closer. So in this particular example, with an LD50 of 700 milligrams and an ED50 of 140 milligrams, the therapeutic index is only 5. So for the purposes of an anxiolytic, a therapeutic index of 5 is absolutely not attractive to safe medicine, because the potential of lethality or of very serious respiratory depression exists in common everyday practice with commonly prescribed doses with phenobarbital. As a result, it is not a drug that is commonly used today. The purpose of this depiction is to try and emphasize how quantile dose response curves can be used to evaluate and to calculate what the therapeutic index is for a given molecule. That is done in the preclinical testing phase before it even gets into humans. And as I've said to you previously, the acceptable therapeutic index is going to be predicated by the nature of the clinical condition for which it's being used to treat. So let's finish section 8 by revisiting what I hope to try and address. We've defined potency and efficacy, and I hope you're able to reiterate what those definitions are. We've explained the concept of dose-response relationships and how we interpret dose-response curves, specifically paying attention to the efficacy being represented as the Emax and the potency being represented as the EC50. To explain how dose-response curves are used to calculate the therapeutic index, how we use this interface between the lethal dose, the demonstrated lethal dose, and the efficacious dose in order to be able to determine what is our window of therapeutic opportunity in which we're able to operate with equanimity. I hope you enjoyed today's section, and I look forward to having you back in class and section 9, in which we will start talking about how we apply all of these principles of pharmacodynamics and pharmacokinetics to the drug development process. Thanks for being with me today, and I hope you learned some new information.